Good evening, everyone. We welcome you to tonight's webinar, Antibodies and Myasthenia Gravis, with Dr. Henry Kaminski of George Washington University. If you've never attended a Myasthenia Gravis Association support group or webinar before, we're so glad that you're joining us. Please visit our website, www.ngakc.org, for any resources or if you need a new patient packet. Following tonight's presentation, you'll get a survey, and in that survey, we'll also list out our upcoming virtual opportunities. And we welcome all. We would love to see you at future programming. I want to introduce our team at the Myasthenia Gravis Association. With us this evening, we have Hallie Walker. She is our event coordinator. We have McKenna Fulton. She is our community program coordinator in Kansas City. And then we have Catherine Clemens, and she is our community program coordinator in St. Louis. So we will use the Q&A for questions this evening, and Dr. Kaminski is going to answer them at the end of his presentation. So if you have a question, please utilize the Q&A. With no further ado, I'm going to let Dr. Kaminski take over. We are so thrilled to have him here this evening. He is one of the brilliant minds in the MG space, and we just appreciate that he's given us time to speak this evening. Dr. Kaminski, I'll let you take it away.
Excellent. Thank you so much. And actually, it's my honor always to talk to patients. I learn a lot from your questions and gain a deeper understanding of myasthenia, which, as you know, I've studied for 30 years. So I have very few slides, actually. And so I have a lot of room for questions, but I just want to tee this up. And with that, to start off, the diagnosis of myasthenia. And you'll see how this relates to antibody testing in a minute. But it all starts with the physician and patient talking to each other about their symptoms, right? There's a particular pattern of kind of classic symptoms that many patients with myasthenia gravis come to and can be easily recognized. And so let me just first say some qualifiers. I said most and may and usually, right? So there's a lot of variation in the kind of symptoms patients have with myasthenia. And everybody out there knows that more, from a personal sense compared to me. And there's been several studies that just came out in the last 6 months that indicated that patients on average take at least a year to get diagnosed, and that's on average, right? So some patients briefer time, and a lot of patients a lot longer, and go through several, we'll just call it several, 3, 4 physicians to ultimately finally come to somebody where a diagnosis is made. So, but everything still starts with that physician and patient considering the clinical presentation, as we call it. So then the physician performs an examination to see if there's clear symptoms on examination, a clear weakness on examination. So as can the patient look up for 60 seconds and then the physician sees the eyelid droop down? That's a classic symptom of myasthenia. With continued talking, especially when taking the history, does the patient develop slurred speech, dysarthria? And that those things can be seen on examination. Or if with arm extension, the arms fatigue, right? So these are all kind of examination findings that allow the physician to appreciate, yes, there's some what we'd call objective evaluation on examination that support the diagnosis of myasthenia. So those two pieces are critically important, as you'll see why as we go through these slides. So then we have very good antibody testing. And when I say very good, about 85% of patients will have an acetylcholine receptor antibody binding test that is significantly elevated. And again, these significantly elevated and 80 to 85% are key items here to emphasize. So one can make the diagnosis of myasthenia based on antibody testing, but also the patient's symptoms and the examination. Those things have to be coupled. And then there's a large number, 10%, let's say, like 1 out of 10 patients may not have antibodies to any of the antibodies for myasthenia. Just I failed to mention there's the muscle-specific kinase antibodies. So maybe like 8% of patients will have that. So you can make a firm diagnosis with the MuSK antibody testing. But some patients don't have those antibodies. The physician feels that the exam and the history is consistent with myasthenia, and then you start going to this electrophysiological testing. So that's with an EMG with repetitive stimulation. That'll identify, depends on who is doing it. You need an expert doing it. 60 to 80% of patients. Or a single fiber EMG, which is, again, a specialized test here in the DC metro area. We have ourselves at GW and then a really expert group in the community who does single fiber EMG, and then the people up the street at Hopkins. So there's not many people who do it. It's not a frequently done test. And so you really need to have physicians that do this frequently are expert. Because as you'll see as I go on, there's a false positive and a false negative problem. So false positive, somebody has an antibody test and they really don't have clinical myasthenia gravis. We'll get into that. And then people who are seronegative, they clearly have the disease, but the testing is negative. So one has to be very careful in those situations in making the diagnosis of myasthenia. Okay, so now I think, as you'll see, it's critically important, not just for diagnosis, but we'll talk about treatment, knowing your antibody status. So there's the acetylcholine receptor binding antibody. That is the most important test in confirming the diagnosis of myasthenia. Now, the reason I say it's the most important, because it's sensitive. So if you have the disease, it will pick it up in, again, I said 80% of patients. And it's very rare to have a significantly elevated binding antibody and not have myasthenia. That can occur if in a patient who has a thymoma, they can have an elevated antibody test, but they don't have any symptoms of myasthenia. Otherwise, there can be just low positive rates of this binding antibody. Now, I know commercially you can order blocking and modulating antibodies, but I would never make the diagnosis of myasthenia based on a blocking and modulating antibody test if the binding antibody is not positive. So I just don't get these blocking and modulating antibody tests. So that can lead down to a path of treatment that a patient does not need. And as you know, all the treatments for myasthenia have some toxicity to them. So you don't want to make a diagnosis of myasthenia when it's not there. And then just briefly, there are these what are called cell-based assays that are being developed. I think the Mayo Clinic may have these now available. However, again, these are new tests. All treatments have been kind of designed on understanding the binding antibody test. And so, in a research setting in the best labs in the world, I think we can count on a cell-based assay but I'm not sure that it's ready for prime time to make the diagnosis. It can be confirmatory. It can help in the situation where the patient clearly has symptoms of myasthenia. Then, as I mentioned, the muscle-specific kinase antibody test, and then there are patients with this LRP4 antibody. And as we talk about this, again, I don't use that as a single test to make the diagnosis of myasthenia gravis. There's false positives that we'll talk about. So I always couple that with that single fiber EMG. And then ultimately you have no detectable antibody. So I think, I'm going to emphasize some of these points. No test is perfect. That's true for any medical test. So as I said, there can be a false positive. And there was a wonderful study that just came out in the neurology journal from an Italian group that looked at hundreds of patients in their data bank. And they looked at those patients who had a positive acetylcholine receptor antibody. And then they did a deep evaluation of the kind of symptoms they had, the kind of follow-up they had, the single fiber EMG that they had. And they came to the conclusion that patients who have this low positive level, so labs differ, but basically 0.5 to 1 nanomolar, in that range, those are much more likely to be false positive. So again, what I mean by false positive is it's a positive blood test, but it really is not indicative of myasthenia gravis. So when there's a low normal or low abnormal, I always go back to that examination and the patient's symptoms and further potentially rely on that single fiber EMG to absolutely confirm the diagnosis. So then there's the additional problem of false negatives. So again, with the acetylcholine receptor antibody, 80% of patients will have that antibody, but that means 1 out of 5 don't. And if you have ocular myasthenia, that's 50% of patients don't have that blood test detectable in their, don't have that this antibody in their blood that can be detected. And we can go into the reasons why later. But especially with ocular myasthenia, often that diagnosis can be made very much by the examination, the demonstration of the eyes not moving together correctly, the eyelids coming down over time, the patient's giving these clear symptoms. Often it's very valuable when a patient brings an actual, photo or a video of themselves. And so I can say, well, at 8 o'clock, you look normal, but at 5 o'clock, that's when the problem is. And I, see the obvious eyelid droop. So again, it's this coupling of the examination and the history and the testing. So then MuSK antibodies, MuSK is rare. We don't have enough information yet to really understand the kind of false positive potential. But in my experience, if a patient comes in with the symptoms that are consistent with MuSK and myasthenia, their antibodies are in the thousands or hundreds. It's usually not a question of a minimal elevation, fortunately. And then, as I mentioned, the LRP4 test can be positive in other conditions. So some patients with ALS, Lou Gehrig's disease, have elevations of LRP4 antibodies. And so the point here, again, the false positivity, it should be usually fairly straightforward for a neurologist to distinguish myasthenia and ALS. So early on in the course of that disease, it may be, a mimicker, as we call it, but clearly differentiated. And when you do an EMG, you can, again, confirm the diagnosis of myasthenia or another neurological problem. So, this discussion of 10 years ago would have been just about diagnosis. But now we have excellent studies that demonstrate that the antibody testing can guide treatment decisions. So kind of the first level, there was the NIH-funded study that demonstrated that thymectomy plus prednisone in this case was beneficial for patients. This is only in patients who are acetylcholine receptor antibody positive, and that's because when you look at the thymus of a patient who's acetylcholine receptor antibody positive, um, my dog is having a little event here. They benefit from the thymectomy. So that's a first stage to know that antibody, whether you may qualify or should have a thymectomy. Then you know about these new therapies, complement inhibitors. I have them listed there: Soliris, Ultomiris, Abrisk, Zilucoplan. That those treatments really are only known to work on acetylcholine receptor antibody positive patients. And that's just the way that antibody works. The MuSK antibody really doesn't activate this complement system, so there's no benefit. So you'd only be getting the side effects with no benefit without that acetylcholine receptor antibody. And then I'm sure people are aware of the FcRn inhibitors, Vyvgart, rozanolixizumab. That's just, those are the major ones now. There was a new one by Johnson & Johnson that just came out. I have no personal experience with it, so can't really speak to it on a personal level. Now that MuSK antibody tests, again, they help in treatment decisions. Those patients with MuSK antibodies in general do not undergo thymectomy because their thymus doesn't have that inflammation. Now, if you've had myasthenia for decades, you may have had a thymectomy and then learned to have MuSK antibodies. But here, for the rozanolixizumab, you qualify for FcRn inhibition in specific cases. And also, the MuSK tends to respond very well with rituximab. That's what's called a B-cell depleter. There's other now bioequivalent forms, but rituximab was the first one. So again, this antibody guides things in terms of treatment. The LRP4 and the seronegative doesn't qualify you for thymectomy or FcRn or complement inhibitor. Now, some of you may have had your neurologist recommend a thymectomy, even though you're seronegative and LRP4. But that's an individual physician-patient decision about that treatment decision. But as a general statement, are the guidelines that have been put together by an international team here in the United States, as well as the UK and Germany and Australia have also established expert recommendations, which differ a little bit across the globe. Japan also the same way. But this kind of regimen here that I've put on this slide is generally, is consistent across those guidelines. So that's why I think you should know your antibody status. So we'll discuss, I have one ending slide just to thank all my colleagues at GW who we have a fairly large research group. Dr. Kushner, some of you may know, runs the laboratory where we're trying to develop markers in addition to these antibodies that can guide how we treat patients better and may predict which drug is best for them, as well as having our own drug development program. Talk about that later. And then in the last couple of years, I've met a um, applied mathematician, and we're trying to improve the way the neurological examination is done and have an objective quantitative metric for that. Um, I can tell you that I would not be here without the National Institutes of Health that has funded my research for 3 decades in different fashions. To also reach out to the Department of Veterans Affairs, where I started in Cleveland and received my first training grants. Without that, I definitely would not have become a scientist. Um, and also, obviously, the Myasthenia Foundation for awards intermittently, and the Muscular Dystrophy Association. Um, and I'm really appreciative of the MG associations that's supporting our rare disease network, the MG net, where we're all working together as a consortium to bring about better treatments. And just as I have my soapbox here, there's really no such thing as myasthenia-specific research. Without the discoveries in immunology and cancer, we would know very little about myasthenia. So the thought that one can only fund myasthenia and come to a cure is just not possible. The drug Dr. Kushner is developing stems from discoveries in the cancer field. So I'll leave it, and the technologies that have been developed in immunology that we can now apply to myasthenia are phenomenal. I know my colleagues across the country would say the same thing, Dr. O'Connor and Dr. Nowak and Dr. Vern Jewell and such. So I'll now really go back to ending the slideshow and opening things up for questions.
It looks like
And
we have several questions in the Q&A. Do
yeah.
you want one of us to read them to you, or do you
Oh, no,
prefer?
I popped them open.
Okay.
Okay. I recently had an MG crisis. How is it that the body suddenly began overproducing antibodies to put one in a crisis? So I'll answer that on different levels. So approximately 40% of patients who go into crisis um, have an infection that appears to stimulate the immune system and generate not just more antibodies, but antibodies that are of a particular type that can be, particularly damaging to produce that crisis. So that, in one sense, that's the easy route where there's a stimulus that we know caused that. In other words, the infection is often a pneumonia. Some patients may be exposed to a certain drug, an antibiotic. I'm sure all of you know and have that list of drugs to use with caution. That's a relatively smaller percentage, but that certainly can happen. And then the rest, we really don't have an understanding, right? So we know that the immune system, that the myasthenia symptoms fluctuate over time. And it's important to know your immune system is just not static. In other words, it's not like just staying the same. Again, hearkening back to Dr. Kushner and our genomics core, we've done a study of specimens from this thymectomy trial, and we can see various genes that are expressed in peripheral blood are fluctuate over time. And so there are some reason that that is producing this exacerbation in those patients that we really, don't have a clue to. So I know that's not a very satisfying answer, but we are trying to understand that. The important thing is, obviously when you have a crisis, to try to modulate that, and that can happen, through plasmapheresis, IVIG, and then coupling that with often prednisone or other treatments to stop that exacerbation. But right now, that's the best I have. How is it that plasmapheresis can filter out the bad antibodies, leaving good ones behind? Well, it's dropping your antibody level of all your antibodies. So it's not that it's just leaving the good ones behind. It's important to note if you only have plasmapheresis um, and then no other treatment, you'll be back in exacerbation in 6 weeks because you're not stopping the antibody producing cells. Um, and so you are still uh, eliminating those quote unquote bad antibodies and those good antibodies. And Allison, I don't know, I saw something pop up that you wanted to add to, or am I confused?
I don't see an, I, s- I think there's some things that popped up in the chat.
Oh, okay. Gotcha.
And if everybody
Oh,
can put their questions in the Q&A versus the chat, that'll help us track them a little better. We have a lot of questions. Thank you.
yeah, I'll keep on going and I'll try to do my best. How would antibodies be present in a person without disease? Right. Okay. So the best example of that is here's the important thing. We talk about an antibody, but it's not a single flavor. There are multiple different kind of types of antibodies. Only some of those antibodies are actually binding correctly and injuring the nerve, the muscle side of the nerve muscle communication point. And as we've learned just in the last couple of years from really some beautiful studies, sometimes, often you have to have a few different flavored antibodies communicating with each other on the muscle surface to produce damage. So there are also some antibodies that may disrupt that bad interaction, even though that they're acetylcholine receptor antibodies binding to that acetylcholine receptor, may not be pathogenic. They may not be causing disease. So that that's one thing. Not all these antibodies are pathogenic. As you probably know, um, I can have patients who have a very low level of antibody, acetylcholine receptor, and they're in the intensive care unit. I have other patients who come and see me and they have very high levels of antibody, but they're doing pretty well. So it's not just the level of antibody that tells you anything. So it's all the different interactions, how tightly the antibody binds to the acetylcholine receptor, what kind of, what I call it, flavor of antibody it is. But to the question, how can you have these antibodies and not the disease? The best example are thymoma patients. So the thymoma induces an immune reaction and you get an elevation of acetylcholine receptor antibody, but those are not disease-causing antibodies. And then sometimes low levels of antibody are seen in patients who have family members with autoimmune diseases, or for example, somebody may have lupus and systemic lupus SLE, which is an autoimmune diseases, and they have low levels of acetylcholine receptor antibodies, but they don't actually have the myasthenia disease. So that's the best I got here. How common is it to be seronegative with thymoma? And what treatment works best in this case? Cell assay was also negative. So that's distinctly rare. Since you've had the cell-based assay, it sounds like you've probably had repeat testing, and it would be reasonable to do that again. However, if you have clearly clinical myasthenia gravis, which you're telling it is, the best treatment is, I'd say the same as one might used for acetylcholine receptor antibody myasthenia minus the other testing, minus those other drugs. So prednisone, depending on the severity, and particular medical situation, if it's not appropriate for you to take prednisone, there's the immunosuppressives, Celsep, mycophenolate, tacrolimus, I think, is a very good medication, probably underused here in the United States. It's the #1 immunosuppressive in Japan. Certainly, IVIG can be used, which I didn't bring up, whether you're seronegative or not. So I don't think there's a single best in this situation, but you fall back to those kind of standard treatments. Okay, what is the significantly elevated antibodies? What is the numbers threshold for that? So as I alluded to, you have to look at the laboratory, but the typical one, the cutoff to be above 0.5 nanomolars to 1 nanomolar. I would say that that's a low level. Again, it all goes back to the patient's symptoms. Do you have myasthenia gravis or not? I think the point here, it's important to have that ancillary testing to confirm the disease. So I'm just going to keep on going with the same question. I am seronegative with positive electronic testing. Okay, that's good. Haven't had positive antibodies, but have increasing antibodies that were just one number away from positive. Also, I was taking immunosuppressants or IVIG when tested. So that makes it more difficult, right? I'm just giving general responses, not specific to your situation. IVIG can produce elevations of, by definition, it produces elevations of antibodies. I've had patients who test positive apparently for hepatitis antibodies, but have never actually had hepatitis, and it's really related to the IVIG. But again, I think it's a little too specific for me to give a general answer to. What about Titin only antibody? I was diagnosed with Titin only, no thymoma. I have generalized ocular weakness. I feel most of my thighs. I have difficulty walking from weakness. Thank you. Okay, so there's the Titin and anti-striational antibodies, which I didn't discuss, because those in and of itself don't make a diagnosis of myasthenia. It's important that individuals over the age of 60 have higher rates of these Titin and anti-striational antibodies, and so that can produce a false positive. In your situation, you have ocular weakness, generalized weakness. You have to work with your neurologist, appreciate that you're weak in your legs and determine what that leg weakness is caused by. So this is another thing that really has to be individualized. Once a patient has myasthenia, that doesn't mean that every problem they have is related to myasthenia. So when I hear about leg weakness in a patient with myasthenia, I wonder, oh, how much prednisone have you been on? Have you developed a steroid myopathy? In other words, steroid-related weakness. That's something that needs to be considered. Oh, as we grow older, we develop low back problems. Do you have lumbar stenosis? Do you have peripheral neuropathy? That all, requires a careful evaluation. But it's very important not to assume that everything is myasthenia. Do you have thyroid problems that's produce weakness? Okay, can you be AChR positive and MuSK positive? Rarely, it's very rare. And, from a treatment perspective, it really, again, needs to be tailored. How high are the MuSK antibodies with that, patient, and how long have you had symptoms? You respond better to the rituximab? Again, that really needs to be very specific to your particular situation. So does receiving IVIG mess up antibody tests? In general, not. Okay, other than these situations that I mentioned, I don't think you would expect it to produce a positive acetylcholine receptor antibody, but then you can always retest. Okay, this is like really flipping here. Do you believe there are more MG antibodies that haven't been discovered? Yeah, absolutely. Allison and I were speaking before this. If you talked about seronegative patients in 1999, that would include all these patients who have MuSK antibodies. And so there's an evolution to understanding the disease. So there have been groups that have found antibodies to other muscle proteins in seronegative patients. At this time, though, none have been evaluated well enough to say that this is actually a test for myasthenia. So the MuSK antibody, the acetylcholine, to a lesser extent, LRP4, that's really gone through some rigorous evaluations to prove that these are pathogenic, disease-causing antibodies. So there are definitely laboratories trying to identify seronegative antibodies. Again, Kevin O'Connor at Yale is making a big effort to do that, but as yet, we don't know. So a thymectomy is typically not warranted, beneficial in patients over age of 60, correct. That, in general, so the guidelines across countries recommend a thymectomy under the age of 50. There are patients who, the clinical trial, this MGTX trial that I referred to, that included patients up to age 65, and they benefited, and they had the same kind of picture of the thymus histology by using a microscope and analyzing the thymus that the younger people did. A colleague in my laboratory did a big retrospective study, so that's not a prospective, but it's some evidence to suggest that patients above the age of 50 and 60 could benefit, but that's a very much individualized discussion with your physician. Thymectomy is very safe, but it has its risks, and then it all depends on your symptoms, so I can't give a blanket statement. Do harmful antibodies for myasthenia cause symptoms of overall fatigue and tiredness? If so, know what causes it. I ask this because a patient can currently score pretty low on ADL, but have great fatigue and tiredness. Yeah, so this is an area that has really become a focus of research in the last 4 years, fatigue and myasthenia. And as you write here, there's the decreasing strength with activity, which we also is called fatigue. But then there's this sensation of tiredness that the patients also have. So I and really the UCB pharmaceutical company has done a set of very rigorous studies to develop a patient-reported outcome measure that has really identified this fatigue issue, the tiredness issue, that is separate than the muscle fatigue. And I have colleagues in the Netherlands and in Germany that are investigating this fatigue phenomenon. And so the question about what else could be causing this? Well, one thought is if you look at interferon gamma, it's a protein that's in the blood that regulates the immune system that goes up when you have a viral infection. And when we all have a virus, we feel pretty fatigued, right? And in some patients, this interferon gamma is increased. And so that might be a reason. There's other inflammatory markers that are higher in patients with myasthenia who have fatigue but are otherwise strong. So, I think we're beginning to understand the scope of the problem. We're beginning to understand um, that there are other aspects of the immune problem in myasthenia beyond those antibodies. I would like to add, though, when you have this sensation of fatigue, you really have to have a deep evaluation for other causes. Again, I mentioned that, the thyroid problems, 10% of patients with myasthenia, thyroid disease, you have to look for low thyroid or high thyroid, sleep apnea, especially if you've been exposed to prednisone, have gained weight. That's a very common cause of fatigue, just insomnia from the anxiety of having myasthenia. You cannot discount these things. And the ravages of all the medications we give for myasthenia, that's going to produce fatigue. A low blood count, anemia is going to produce fatigue. So you need to work with your primary care doctor to, again, not assume that everything is myasthenia. And I've had numerous patients over the course of my career that I think they have a sleep disorder. They get evaluated, they get appropriate treatment, maybe not necessarily a CPAP, but some other therapy, and they're significantly better. So, um, um, okay, so really quick, 50% false negative rate in AChR testing. Is that the seronegative population or assay challenge? No, it's the seronegative population that we're talking about. It's the binding antibody test is a very good one. It stood the test of time. The cell-based assays may improve the sensitivity a little bit, but it's the best test we have available. Well, I think there's always hope, generally hope. Um, so there's a question about to hope for seronegatives. I mean, there are groups that are working on this. It's a very active place for, trying to understand and trying to study. We appreciate, I'll tell you, it's frustrating for the patient. It's frustrating for the doctor, right? Because I have a sense of um, greater certainty when I have that blood test, when I'm giving a toxic agent to a patient. And so when we don't have that antibody, it limits our treatment options. And so um, it's a point of frustration for the entire field. Um, okay. My question as a patient and a rising third-year medical student, congratulations, good luck, is what kind of things are on differential for patient as false positive antibody tests? Okay, so I'll hit those really quickly. Like you need to look for a thymoma, you need to look for other immune conditions, like lupus, rheumatoid arthritis. Those are things you need to take a good family history just to make sure that there's not a prominent um, history of numerous autoimmune diseases. So those are the kind of things you should do. And so then presumably if they are being tested, they have symptoms of some kinds of not MG, what kind of things would you look for, right? Well, so the ones I mentioned, something that should come up also is, and it's become is frequent, is complications of COVID infection. As patients have fatigue, they have blood pressure problems, cognitive issues. And so, in the last month, I've seen two patients with long COVID who've come to me with the question, do I have, myasthenia gravis because the levels of fatigue. So I think that's also a consideration. And then also, there's a condition called um, paroxysmal orthostatic tachycardia, POTS disease syndrome. And so that's a blood pressure issue that causes fatigue. I've seen patients with that who are sent to me for evaluation. So those are the kind of things you kind of consider. Well, so that there's a the question about elevated free light chains and diagnosing seronegative patients, that is just not been researched adequately. I can't emphasize that more. There are a couple studies about these free light chains, and when you dig deeper in this, they are comparing this to patients to normal controls. That's irrelevant. If somebody's normal, that's not a question in the clinic. The question is somebody who has fatigue and other problems, do they also have elevated free light chains? And those free light chains go up when you get older as well. So this is just completely inadequately studied. And I know that there's a balance of publishing work to garner new information and new ideas, but it also has to have some really clinically robust science behind it, as opposed to the final statement in all these publications of more research needs to be done. Well, then you should probably have done more research than to confuse the world with this. Anyway, so there's a lot of seronegative questions. I'm going to just kind of, okay, so this is a little different flavor. Can you explain what is the complement inhibitor versus an FcRn? Yeah, okay. So there's this system in our bodies called complement, and it protects us from bacterial infections, typically. And so when an antibody binds, the acetylcholine receptor antibody, in our case, binds to the acetylcholine receptor on the muscle surface, this complement system gets activated, and it basically busts open a hole in the muscle surface. So when you have a complement inhibitor, it stops that process. Now, an FcRn inhibitor works completely differently. So our bodies make a huge amount of antibody. And so there's a system for the antibody to be brought into a blood vessel cell, and then it's sent back into circulation. So it's not degraded like other proteins. And this allows the body to maintain a high level of antibody. So these FcRn inhibitors, they stop this process of recycling. And so all this antibody gets destroyed, including the ones that are causing the disease. So your antibody level drops. Complement system is still there. So that's the different. They work completely differently, and so is one better than the other? There's never been a study that compares the two. FcRn, it's taking out many of these pathogenic antibodies. The complement inhibitor works in just a certain way, and there's some patients who respond well to either one of these, and some patients don't respond to either. So again, trying to figure out what patients respond to what treatment is very important. So the agrin antibodies, so again, this is within the research realm. I don't think we're ready for that at all. Do the values of MG test results indicate more than just positive? So the acetylcholine receptor antibody, when you get treated, they tend to go down, but it doesn't tell you how severe the disease is. I've had patients, again, like very high levels, and they're fine. And I've had other patients who have very low levels of acetylcholine receptor antibodies, and they're very weak. So they really don't help other than in diagnosis. Now, the MuSK antibody tests, when a patient is treated, they generally go down. So that's very reassuring. And some, again, still limited studies show that when patients are about to have exacerbations of MuSK myasthenia, they start to go up before that. But that does not mean that you should have MuSK antibody testing to try to predict those at that point. I would never treat a patient with a toxic agent just based on the antibody. You have to be symptomatic to warrant that. Okay, I've got a very, very special question from a very special guy, the guy who taught me everything, who started my career in science, none other than Robert Ruff. He probably knows the answer to this question, so I don't know why he's even asking it. In my experience, people with MG often have other autoimmune disorders. Do you know if there are specific autoimmune conditions that commonly occur with MG? That's a very good question. So specifically, thyroid disease, right? So about 10, 12% of patients can have hypo or hyperthyroidism. Sometimes it comes on at the same time. That low thyroid or high thyroid can produce fatigue and weakness. Dr. Ruff did a lot of studies on thyroid related muscle diseases. And so that's a very important one. Now, I would not say it's anecdotal. I think now there's been a good number of epidemiological studies that demonstrate that thyroid abnormalities are common. You know, I agree when I look back at my number of patients, they're disproportionate, but I think there's good studies about that. I think some of the anecdotal ones are like, is vitamin B12 deficiency, which can be an autoimmune condition, you know, that's I tend to test for that in patients with myasthenia, although I don't think there's a whole lot associated, you know, to confirm that. And then, you know, people with lupus and rheumatoid arthritis have higher rates of myasthenia, but then I'm looking for that when the patient is having those symptoms. I'm just gonna. Oh, okay. I'm a bit concerned about what you said with regard to not diagnosing a patient that is only positive on blocking or modulating. I recently met with the spoke doctor at MG contrary stated that antibody cannot block or modulate it if it is not also binding. That's a good point to make. That's correct. Can you please explain how you would approach a case when patient's positive on blocking or modulating, but not on binding, and they are very symptomatic? Okay, so this is a good point. There's a very different evaluation that Dr. O'Connor does in his laboratory versus what LabCorp or Mayo Clinic is doing. So first of all, the modulating antibody, that requires very specific care of the sample. So technically, a patient has to have their blood drawn and that blood kept appropriately and processed within 30 minutes. If you go beyond that, you have much higher rates of false positivity with that. So that's one of the reasons I would never rely on modulating. And you're right. If you got a modulating antibody, it's binding to the acetylcholine receptor. The thought is it's on these cells, and so it's presented differently, but it better be binding. And the blocking is a technicality of the way this test is done, because you label it with a certain peptide, and that peptide can block the formation of an antibody on the surface. So that these are all technical issues with the testing. But from a clinical perspective, when I say clinical, it's from me as a neurologist trying to diagnose a patient correctly. You got to go back to the history, physical, what the patient is presenting. And one of the reasons I'm harping on this is I have seen many patients in my career, one just recently, who had the diagnosis of myasthenia based on a minimal elevation of a blocking antibody. reviewing their notes from the original presentation, she didn't even sound like she had myasthenia. I never would have even ordered the test. Yet she's gone through recurrent plasmapheresis, recurrent IVIG, has gained 50 pounds related to prednisone treatment, now has sleep apnea, osteoporosis. She's devastated from the therapies that she's received, and I don't think she ever had myasthenia. So that's why I think there's harping on the combination of what the patient is experiencing is so critical. Just okay, so 21-year-old daughter with antibodies, positive single fiber test, thymectomy 2 years ago, tried Ultomiris, Zilbrysq with no positive test results, takes Mestinon, IVIG, multiple exacerbations. Well, I can only give you the kind of standard things that, I mean, we haven't emphasized here, but I'm not seeing immunosuppressive treatments on this list. So for a young lady, you don't want to use mycophenolate, that can also called Celsep, that can cause birth defects. But tacrolimus, again, an immunosuppressive treatment, can be used very safely. I'll tell you what, one thing about these new FDA-approved drugs, none of them stop antibody production. So they're really not getting at the root cause of the disease. So to answer the question, I think immunosuppressives, prednisone can be used safely. I'm not sure in this case because I need to know the details, but I think that needs to be evaluated. Yes, it's a nasty drug, but prednisone remains the single most consistently effective drug for myasthenia gravis, period. And some patients are highly sensitive to this, to prednisone, and don't require exceedingly high levels. So again, I didn't see it listed here, and so I think that's a consideration. Rituximab has been shown in an elegant study out of Sweden to significantly improve patients with early onset myasthenia in the first year. So if you use it early, which is not exactly this patient, that's a consideration, but you have to have a one-on-one discussion with your neurologist about that consideration. A neuromuscular neurologist in a lecture recently said that MG can evolve over time, which might explain why an MG's drug efficacy or symptoms might change over time. Could that be true? Well, so I wouldn't use the word evolve necessarily because that suggests that there's a certain pathway that it's following, but it definitely fluctuates. And, all their treatments are trying to impact that fluctuation. I mean, one patient I'll tell you the story of that he had come in with a crisis, started on prednisone, he got out of the hospital, was on IVIG, but he was still significantly impaired. He placed him on mycophenolate, for a few months. That wasn't doing anything. Fortunately, at that time, Soliris had just come out, and he did great. I mean, it was remarkable. Stayed on Soliris for a year, was doing fine, and over the course of a week, again came into the hospital in a crisis. This time responded beautifully to IVIG and got better, and then the mycophenolate kicked in, which can take 6, 12, 18 months to work now. So clearly in this patient, something fundamentally changed about the antibodies he was producing, and that complement system inhibition no longer worked for him. Why this happened, we don't know. He didn't have any infection. There didn't seem to be any sort of exacerbating reason for that. So it changes over time. There's no question. The nature of these antibodies and their production changes. Okay, so it's been an hour.
And you, I don't know how you, if you want to wrap up things or if you want to answer any more questions. This has
Well,
been
yeah. So
so fabulous.
I'll try to go through, things that are different, just maybe for another 10 minutes. Um, is there any research being done connecting COVID and myasthenia? So I think that's the scientifically fascinating question. Um, there's no epidemiological studies that suggest there's been a spike in myasthenia after, well, our ongoing pandemic. But we know the immune system gets activated by COVID infection, gets activated by COVID vaccination, as it should, right? That's what vaccinations do. And that some patients seem to develop, or not seem, but develop myasthenia soon after infection. There was a particular patient early in the pandemic that developed a crisis after COVID. He had cleared, within 4 weeks. I had a patient who had vaccination and bang, in 2 days, she developed myasthenia. There's no question, and every expert still recommends vaccinations are much safer than having the natural infection and having myasthenia. So uh, that there's no question about that. I think there might be some individual sensitivity in the genetics of a person, and the nature of the COVID virus they received and the vaccination that could potentially trigger myasthenia. Or we know that the COVID infections generate increased inflammation. It's sort of the basis of the long COVID infection. So it's and as I said, I have patients who come in who turn out, we diagnose, determine that they have long COVID and they don't have myasthenia gravis. So that's again something that needs to be fully evaluated and understood much better. And as I understand, the NIH support for long COVID um, studies is going away. So we'll probably never have an answer here from United States research studies. And it's the COVID virus produces very different kind of symptoms in patients, and it can actually, in some patients, it alters their muscle metabolism, which is an explanation why patients with long COVID often don't do better with exercise, which in general is a very good thing for nearly all conditions except in long COVID, because there's fundamental difference in their muscle metabolism. So the reason I bring that up specifically, I think there might be a lot to learn from these long COVID patients going back to fatigue and myasthenia. It's not everybody that has that, but fatigue can be disabling in some people.
I don't know, Dr. Kaminski, there's some questions that people also put in the chat. So I don't know if you want to briefly
Okay,
look at those and see if any of them are
okay,
different.
I'll flip. I had a question about being on long-term prednisone and how it can affect antibody testing. So I alluded to that treatments for myasthenia do drive down the acetylcholine receptor antibody. and some more than others. If you're starting off with a low positive and the prednisone treatment drives you down, that certainly can affect the antibody test. I think from a practical perspective, the key is you're looking for the diagnosis initially, a firm diagnosis with a appropriately high, at least greater than one antibody binding test to be positive. And then I don't monitor antibody levels once I'm acetylcholine receptor antibody levels once I'm convinced of the diagnosis, because it's not going to help me treat a patient. So I hope that answers that question. It starts with that you have been um, um, clearly diagnosed based on an elevated antibody test, because otherwise it's not going to change the way I would treat you. What does taking CellCept if you are no longer taking prednisone but are taking methadone receiving IVIG every will it reduce time between IVIG treatments? Yeah, so the point of these immunosuppressives, so that's CellCept, tacrolimus, azathioprine, is they're called steroid-sparing agents to be able to reduce the need for prednisone, which I acknowledge is a bad drug because of its severe side effects. It's a great drug because it can be very effective. But if you're on the CellCept and you're on IVIG, that's a common thing that I would do. But as the CellCept kicks in, 6 months, for example, I try to taper off the IVIG. So I would typically extend out from every 4 weeks to every 6 weeks. See how the patient does. Do that for several 6-week periods, and then go to 8 weeks. By then, the first infusion is gone. And so if you're not getting weak right before the next infusion, you probably will not need IVIG, and then I would cancel it out and just rely on the CellCept. And that, the kind of picture that I just painted is very common in what I do. They'll get a patient on prednisone, start to get them better. They have, side effects, as they all do. Place them on mycophenolate or tacrolimus. But because they're weak, I've started the IVIG to get them much more functional, and then taper off the prednisone to a safe dose, maybe 5 milligrams a day, 7.5. Again, it depends on each person. Wait for that CellCept to kick in, then start tapering off the IVIG. Then you're ideally with essentially no symptoms, right? That's the goal. A little bit of double vision when you look all the way out. I'm not going to count that. And then over a couple of years of symptom-free on CellCept alone, to start to very gradually taper off the CellCept. So, I think that's a kind of a good case scenario. Okay, I think I'm starting to lose my voice.
We so appreciate you taking even the additional time to sift through the many, many questions, Dr. Kaminski, and the wonderful presentation that you gave tonight. Thank you again for your time, and we appreciate it so much. And if your question wasn't answered, we apologize. We've run out of time, and we hope you'll continue to come to our webinars and learn more about MG in the community. Have a good night. Thank you.
Thank you. Take care. Pleasure
Bye-bye.
seeing you.
Thanks.